Today, I wanted to show you a clinical finding of a bronchopleural fistula. Somehow I find the clinical findings are quite important. I do understand we need to talk about imaging, about intraops and other things, but if you have not got clinical clues, you will lose track of the trajectory of the patient's problem. So I somehow feel a lot of importance has to be given to clinical observations, clinical findings. So this reel is about the clinical finding of a bronchopleural fistula. And of course, I will touch a little bit about the management options. And this is my disclaimer slide. And as usual, please don't think this is a shortcut for real patient interaction and picking up real clinical skills. So this is an ICD which has been placed for whatever reason. If you want to know whether the ICD is working, then what you need to do is you need to see whether the column is moving in the back. You can see that the column is moving in the back. Fine, that is it. It is moving, so it is working. Now, let's have a look. This is another ICD. The column is moving well, but there is some minimal air leak. Have a look. You can see the column moving between and little bit of air leak is there. After the air leak, the column is moving. So there was a minimal air leak and we just managed conservatively and they all settled down. Now let's go further down. Have a look at this. I have not even edited the background noise. This is how you will be working. There'll be alarms, monitors, movement, talk, some patient fighting, some patient crying, police running around in the ward taking statements. Administrators will be pushing for the billing. You have to work with this. That is why I have not even masked the background voice. In this, you must hear the breath sounds. In this, you must hear the air bubbling. Okay, so this is a bronchopleural fistula. That means the pleural cavity is communicating with a reasonably sized bronchus. Not a small alveoli, but a reasonably sized bronchus. So bronchopleural fistulas, they are encountered after pulmonary resection, where you are likely to incise a major bronchus. Now, the clinical radiographic and bronchoscopic findings that confirm an air leak from a bronchus to the pleural space are used to diagnose a bronchopleural fistula. So, it's not only clinic. Now, you have to go further. You have to localize where exactly is the leak. You cannot open up the whole thoracotomy and look for the leak. You have to find out where is the leak. Sometimes you might need to do even a bronchoscopy to find out where is the leak. So, three things are needed. What I showed you was only the clinical part. Now, bronchopleural fistulas do not typically close spontaneously and almost always require some surgical or bronchoscopic intervention itself. The second leak that I showed you was very minimal. It stopped by itself. So, it's probably from one of the very small bronchioles. Now, what are the strategies that you can do at decreasing peak inspiratory pressures? Most of these patients will be ventilated also. So meanwhile, while you get to do this bronchoscopy or open surgery, you can do something to decrease the peak inspiratory pressures, because when you bring pressures down, the bronchus is likely to collapse. Otherwise, it will remain open. So you can use lower tidal volumes. These are the respiratory mechanics which you can tweak to maintain pressures down and leak less till you find some definitive therapy. Lower positive end pressure, PEEP you can low, decrease the inspiratory time and decreasing the respiratory rate. Do something or all of them to somehow try to keep the flow rate from the bronchus into the pleural cavity down till you find a definitive treatment. Minimizing negative intrapleural pressure decreases airflow across the bronchopleural fistula. So this tweaking will help bring down the intrapleural pressure. So what are the methods? You can either do surgical method or you can do a bronchoscopic method. In surgery, you can do a thoracotomy itself, or you can do a video assisted thoracoscopy. Both ways you can enter the thorax. This is open, very invasive. You have to open a rib space, whereas this will be your minimally accessed surgery. Or you can even avoid the small incision and do it through the bronchoscopy route itself. But that you can do only when the fistula is less than 8 millimeter in circumference. What can you do through the bronchoscope? You can put blocking agents, or you can use occluders. You can put airway stents. Sometimes endobronchial valves and spigots have come. Finally, mesenchymal stem cells and 3D printed stents, which will exactly fit into the gap. It will neither cause pressure necrosis of the mucosa, nor will it be suboptimal to let a leak continue. They will be exactly printed, 3D printed stents can be used. Now, if there is a recurrence, what you can do? The final port of call will be your thoracostomy. That means make a small opening and leave the pleural cavity open to the atmosphere, so that they will not be having any other issues. Your lung will be able to expand now. This is what people were doing for empyema in all those days. We used to do a thoracostomy and the pus will keep draining. This was about 30 years ago. So thank you again. Subscribe to my Telegram channel. I'm repeatedly putting questions and multiple choice and quizzes and videos there. And thank you again once again.